I don't think I am visible. No. I don't think I am visible. So now, yes, I am there, and my students are also there. So a very good evening to all of you. I think now I am audible and visible. Okay, if you can just show me a thumbs up that everything is going well, so we can start the session. All right. So good evening to all my dear students. Welcome to the session. And here I am, Dr. Shivani Jain, your NEET PG mentor at DocTutorials and Ophthalmology. So welcome to the session, guys. We know that your exams are approaching and just 35 days are left for your exams. And if we talk about our FMG students, less than 50 days. So it's now, I know it's not a very large time that you have, but definitely it is the most precious time of your preparation, isn't it? These 40 days, what you have in your the preparation, this is going to be very, very important. That will mark where you stand in the rest of the days. Okay, so sound बहुत कम आ रहा है, Dr. Success, can't you hear? Is the problem with sound everywhere? Please let me know, students, if the sound is problematic. I'll fix it. Okay. Okay, hi, Dr. Pankaj from Jaipur. So friends, this session will be a very, very important session, not for only our NEET PG students, but also for our foreign medical graduates, because I'll be covering not only these top 25 images, but I'll deal with almost 70 images in this session, and we'll cover 25 concepts so that you can excel in your preparation. Guys, after attending this session, I'm sure that you will have a lot of confidence in ophthalmology, and you will be able to revise whatever you have prepared. You will be able to revise those things in a quick succession of 1 hour. So let's not waste much time, and let's get set go with the top 25 images in ophthalmology for our NEET PG and FMG students. Okay, so this is gonna be first. I am requesting all of you that not to go with the diagnosis only. Just go through the picture, just see the picture. What is the clinical question that can be asked to you? What can be the management here? All the important points we will be discussing very quickly. Okay, so I want you to respond to me quickly. Think about the image, think about the topic, and whatever comes to your mind, you can just write down in the live chat box. Okay, so that is the way how we have to prepare. That is the way we have to revise the things. Okay, not only the revision, you learn new concepts also here. So guys, this is our first image. This is a very, very important sign, a clinical sign that we see in patients of thyroid ophthalmopathy. So when I say lid retraction, that you see here is again a excessive scleral show, isn't it? You see excessive sclera here. So this is the first important lid sign in thyroid eye disease. Okay, now guys, whenever you see lid retraction, maybe unilateral or maybe bilateral lid retraction, this lid retraction will be there in thyroid as the most common feature. And please remember, lid retraction, the cause is also thyroid. Okay, if you see unilateral or bilateral lid retraction patient, just take the history of thyroid from him. So this is the first picture question from thyroid. Another sign which is again very important clinically is your von Graff's sign. So this is von Graff's sign is what? When you look down, the upper lid lags behind. It is not following your globe. Okay, you see this scleral show again when the patient is looking down. So this is not normal. Okay, so this is called as von Graff's sign. So now two very important picture questions from thyroid. One is lid retraction, that we call as Dalrymple sign. Second is von Graff's sign. So Dr. Patel and somebody who says Graves disease, Dr. Nandini, I would like to mention, bache, it's not only in hyperthyroidism that you see such signs. Please remember, please understand, hyperthyroidism may you will get it very commonly, but you can also have lid signs, thyroid eye disease, even when the patient has a euthyroid state. So please remember, even if your patient has a euthyroid state, or even a hypothyroid state, then also you can have thyroid related eye features. Please remember, okay? Now my question to you is that if you have a thyroid ophthalmopathy, what appearance will you see in imaging? What bottle sign is there? Can anybody tell me which bottle sign is there in imaging? So in imaging, what we get is a Coke bottle appearance, okay? So when you do imaging, the characteristic thing is that you have a inflammation of the muscle, which is there only in the belly part. Your tendon is always paired, okay? So please remember, this is a very important sign. All right, so this is the first picture. Now let's go with the second picture, something from your retina. So guys, what is it? Can you tell me? So if you see here, it appears that there is a hypopyon, isn't it? It appears that there is a hypopyon, but this hypopyon is an inverse hypopyon. So we call this as hyperolion, isn't it? What is it? This is not a true hypopyon, but an inverse hypopyon. Exactly, this inverse hypopyon is nothing but your silicone oil in anterior chamber. Okay, so what happens, guys, when we do this pars plana vitrectomy? Whenever we are doing a pars plana vitrectomy, we cut out the vitreous, isn't it? We cut the vitreous, and then in order to prevent the collapse of the vitreous, we put something as a tamponading agent, and this tamponading agent is usually a silicone oil or a gas. Now when silicone oil is being placed in the posterior segment, sometimes emulsification happens, and when there is a emulsification, what can happen? It comes into your anterior chamber, and because it is heavy, it settles down in the upward part of the anterior chamber. All right, please remember, this is a very important concept, okay? So it looks like a hypopyon, but it is not a true hypopyon. It is an inverse hypopyon, okay? Important question, friends, right? Now this is again a picture question. They'll give you this image and ask you which procedure is this. So you have to identify this is a pars plana vitrectomy. It is also called as a 3-port pars plana vitrectomy. All right, please remember, this is also an important picture question. Now the third picture, a very important spot diagnosis. What can this be, friends? So I can give you a history. There's a history of sudden loss of vision in a 65-year-old patient who has atherosclerosis, who has hypertension and diabetes. So what can that be? So very important. This is called as the cherry red spot that you see in CRAO. So central retinal arterial occlusion. You see this white retina, isn't it? This is your white retina, and just in the middle, just at the level of fovea, you have this cherry red spot. Okay guys, a very important topic. Now guys, yes, it is definitely CRAO. Now friends, please remember, there are other differential diagnoses also for the cherry red spot, and it's a very easy mnemonic. Cherry tree never grow tall in mud and sand. So remember, C here is two things, CRAO and your carbon monoxide poisoning. T is Tay-Sachs disease, N is Niemann-Pick, G is generalized gangliosidosis, T is your trauma that you see in Berlin's edema. M is metachromatic leukodystrophy, also in methanoid poisoning, and S is Sandhoff's disease. So these are your differential diagnoses. Please remember, this can also be a question, right? Now here is a very important question for our PG students. So guys, what is this? Again, a spot diagnosis. Anyone from NEET PG or NICT student, what is this? A spot diagnosis. So this is a very important topic again, guys. If you see here, the retina has become white. This is the white retina, but actually what we see here as marked in the black arrow, this is your perfused retina. This is the normal retina. So this is a CRAO with a preserved cilio-retinal artery. Okay, so this is CRA is your preserved cilio-retinal artery. All right. So Dr. Mukul, so see, Berlin's edema is not a true edema. First of all, you need to understand. Dr. Mukul, Berlin's edema, we don't actually have a edema. There is no true edema. It is because of the photoreceptor damage that we see a whitening of the retina. It is the reflex which comes up. When you see a white retina, the cherry red spot has to be there. But if you say edema, the Berlin's edema itself is a misnomer. Am I clear, Dr. Mukul? We see a true cherry red spot, but the word edema, this edema is a misnomer. We don't have a edema, a true edema in Berlin's edema. All right, Dr. Mukul, I hope your doubt is clear now, bache. And Dr. Bishwas, this is not CRVO, beta, this is CRAO. Right, now in this image what you see is that you have a central retinal arterial occlusion, but actually your cilio-retinal artery is still perfused. Now please remember friends, this is a very important topic. Cilio-retinal artery actually comes from the choroidal artery. It is not your central retinal artery branch, it is coming from the choroidal artery. So the macula sometimes get another circulation, another, the macula sometimes may have a dual blood supply, and sometimes when there is a CRAO, this choroidal artery, this cilio-retinal artery may remain perfused, so you will not have a gross loss of vision. Definitely there is a CRAO, but your perfusion will be there in the cilio-retinal artery. Okay, so this can be an expected question, or expected picture question. Now let us go with this question, something similar to this. I want our PG students to understand this topic. Okay, so we have a 50-year-old patient who is diabetic, hypertensive, and there is a sudden vision loss in few hours. Now the pupils are normal and retina shows this picture. So what can that be? Now here guys, please remember the whitening is seen only in this area. So this has to be a cilio-retinal artery occlusion. Okay, there's a cilio-retinal artery occlusion. There is not a true CRAO. Here the occlusion has happened in the cilio-retinal branch, right? So please remember, this can be an important topic. Now let us see the fourth image, a very commonly asked question, something about this cobblestone papillae. Now guys, why do we say it is a cobblestone? First of all, because this is your cobblestone, when you're walking on the pavement, so something like this, your papillae has become very large. They take a shape of a cobblestone. Okay, so where do you see this cobblestone papillae? You all must be knowing that we see this in vernal keratoconjunctivitis. First of all, please remember this. Okay, now you know most of the things about VKC. I just want to show you few more images about VKC and we'll quickly revise. Very good dream catcher and everyone, this is typical VKC. Now guys, normally papillae are like this, velvety, red, shiny, and follicles are opposite. They give you a sago green appearance, right? But when you have very large papillae, it becomes cobblestone and they look like this. Okay, picture questions. Now VKC, as we know that there are so many things. It's a type 1 hypersensitivity reaction to an exogenous allergen. You have boys, young children, small young boys who come with this kind of presentation. They have itching in summers. Now some important signs are also there which I want you to understand. The first important thing here is the Denny-Morgan line. What is that, guys? Can you see these extra lines here? These are called as Denny-Morgan lines. Okay, now what is this Maxwell line sign? So friends, many a times what you get is a ropey discharge. Okay, this ropey discharge becomes very thick, and when it gets accumulate on your palpebral conjunctiva, because of the change in the temperature, it takes up a layer. It takes up a shape of a layer on your palpebral conjunctiva. So we call this sign to be Maxwell line sign. Okay, ropey discharge gets accumulated on your palpebral conjunctiva and then you call it a Maxwell line sign. Okay, so two things. Which is trachoma mein, Dr. Mukul again, trachoma you don't have cobblestone papillae. Okay, you have follicles, you may have papillae, but you don't have big papillae. You don't have cobblestone papillae in trachoma. Please remember, Dr. Mukul. Clear? Chalo. Next thing what you see in VKC is a shield ulcer. Okay, this is your shield ulcer typically, which is seen in the upper half of cornea. Okay, please remember, this is again a question. Right? Now, important question. So guys, when you see this picture, again you will have big large papillae. Right? So you may get confused whether it is VKC or whether it is GPC, giant papillary conjunctivitis. So picture can be very similar. What is the difference here? In giant papillary conjunctivitis, you will have a history of a mechanical insult. Right? This mechanical insult can be because of a contact lens, especially the soft contact lens, then sutures, eroding sutures or any kind of prosthesis. So these will be the causes of giant papillary conjunctivitis. But in VKC, the history will be absolutely different, and then you have a number of other signs as well. Okay, so just by looking at these cobblestone large papillae, do not make this mistake of telling this is a VKC. Large papillae can also be seen in giant papillary conjunctivitis. I think this is clear. Very good, Dr. Sudeep. You will have a history of soft contact lens usage or any kind of mechanical trauma. Okay, very good, Dr. Sudeep. Good. Now, our fifth image is a very important one. We are expecting this in your exam, right? Guys, so this is your central serous retinopathy. What you get is an umbrella pattern, which is also called as a mushroom pattern. You also call this a smokestack pattern. Now, please remember, friends, this is a very specific presentation, okay? This is a very specific picture that you see in CSR. Now, I would say that here, which barrier is broken? Outer blood retinal barrier or inner blood retinal barrier? Where is the collection of the fluid? Can anybody tell me? What exactly is the layer where the fluid gets collected? So this is in your subretinal space, okay? Subretinal space, and there is a breakdown of outer blood retinal barrier, okay? So these can be some of your expected questions. Now, something more about this CSR. So friends, what we see in CSR is a positive scotoma. Please remember, there's a difference between a negative and positive scotoma. I've seen students asking me, ma'am, what is this negative? What is this positive scotoma? So positive is what? You see a black dot. You see something positive. Positive is you see a black spot right there in front of your eye. This suggests that you have macular problem, right? What is negative scotoma? Negative means you don't see anything. It's negative. It's nil. So right there from the picture, something is missing. Okay, this is negative scotoma, and that you have in glaucomas, okay, optic nerve disorders. Please remember first of all this fact. What is the difference between a negative and a positive scotoma? Positive is with macular pathologies, and what we are here talking about is CSR. I think this is clear to you, what is negative and what is positive. Now, so you have risk factors, you have type A personality, young patients, steroids, smoking. This history is very important. What you see clinically is a halo reflex. What we see is, this is a halo reflex right there at the macula. Now, on FFA, you can also see a ink blot appearance, which is the most common appearance. In ink blot pattern, there is an increase in hyperfluorescence in the successive films. So as you take on the films, right, after a few seconds, when you see the hyperfluorescence, it will be increased in size and intensity. So this particular pattern is called as the ink blot appearance, okay? I hope this is clear to all of you. Is this clear? Something about your CSR? So I was mentioning about which layer the fluids get accumulated. So friends, this is our optical coherence tomography picture, and this is your fluid collection typically in your subretinal layer, okay? This is very important, and that has been there in your exams earlier, in NEET PG exam. So you were asked about the fluid collection, where in which layer the fluid is collected. It is there in the subretinal layer, okay? Important picture question. Now, something about instruments, guys. So we also expect some kind of surgical pictures. They'll give you which procedure is this, or any kind of video, or any kind of instrument related to the surgeries in ophthalmology. So this is one keratome, and on the other hand we have a crescent blade. So guys, kera means what? Kera is cornea, and tome means making a cut, making an incision, okay? So this keratome is having a sharp edge at the end. Because it is sharp, it is used to make a clear corneal limbal incision or a limbal incision when we do a phacoemulsification surgery, okay? Please remember, this is with keratome, okay? Now what is the second one? So the second instrument is not as sharp as keratome. This is having a blunt edge. Can you see? This is having a blunt edge. So this is a tongue-shaped instrument which is used for dissection. In which surgery are we using it, guys? So this is again a picture question. The use of crescent knife is with small incision cataract surgery, okay? What are we doing here? Instead of making a clear corneal incision, friends, we are making an incision at the sclera, a partial thickness incision. We are dissecting this towards the cornea, and the rest of the steps are same. We are delivering the nucleus out of this sclerocorneal tunnel that we have created with the help of crescent knife, okay? So please remember the surgical picture. Please remember also the two knives. One was keratome, another is a crescent blade, okay? Very good, Dr. Dreamcatcher. This is for creating a tunnel, okay? Another picture where we are doing, when we are making a nice tunnel here with the help of this crescent knife, okay? Now, here comes another important picture question. So this is your bullseye maculopathy, friends. You know bullseye, the dart game, you know. So very commonly this question, this question has been asked previously, but a picture question is yet to be asked. So what you see in the retina is an area where there is a clear area, then a hyperpigmented area, then a hypopigmented zone. If I just magnify it, you see here a pigmented area, then a depigmented area. Okay, so this is typical of the bull's eye maculopathy. Now here guys, I've written all the conditions where you can have that, but I want you to remember that chloroquine and hydroxychloroquine are the very important drugs. Now friends, the important thing to understand is that it is not a single dose or a very short term course which can result in this. The problem is when you take this as a chronic use, when you take this for almost 5 years, more than 5 years, and when you have a cumulative dose, like for 2.5 milligram per kg body weight, and for HCQ it is 5 milligram per kg body weight. So when you take this much dose for more than 5 years, then these drugs can damage your retinal pigment epithelium. Okay, so there is a damage of photoreceptors as well as your retinal pigment epithelium. Okay, now when this happens, you get some kind of dartboard game pattern in your macula. So obviously in the initial stage your vision may not be defective, but as you keep on taking it and then the retinal pigment epithelium gets damaged, then definitely there's a deterioration in central vision. So please remember the drugs related to bullseye maculopathy, which layer in retina gets damaged, and what is the cumulative dose and how many years. So these are all the questions that you have to remember. Okay, very important question. Now next important image is about Duane's retraction syndrome. So friends, I would like to say, first of all, just appreciate what is happening in this particular picture and all the three gazes. So the central one is a primary gaze wherein I see everything appears to be normal, isn't it? Everything appears to be normal. But when the patient is looking on the right, that is dextroversion, this is okay, this is okay. But when we see carefully, we find out there's a slight retraction of the globe. The eyeball is slightly going inside. Okay, so again I'm telling you, when the patient is looking on the right side, the movements are okay. But the adduction of left side is accompanied by a small retraction of the globe. Try to appreciate this, friends. So, what is happening on the third picture when the patient is trying to look on the left side on the levo version? So, if you see, abduction is deficit. So, abduction is defected, isn't it? So, first of all, please try to see what is happening here. Now, as you see this picture, the first thing which comes into your mind is that this is a sixth nerve palsy, isn't it? Because left eye abduction is faulty, isn't it? Left eye abduction is not happening. Now, please remember, differential diagnosis of sixth nerve palsy is this, Duane's retraction syndrome. So now how to distinguish? The most important distinguishing factor is that when there is an adduction of the eye, defective eye, you will also see there's a little retraction of the globe. So the basic problem in this patient is that the left lateral rectus, which is normally innervated by the sixth nerve, is not happening. You remember, you know it, that lateral rectus is supplied by sixth nerve, isn't it? But here, lateral rectus, instead of getting nerve supplied by sixth nerve, it is getting supplied by third nerve. So when the eye adducts, medial rectus and lateral rectus co-contracts, they contract together. Now imagine if this is your eye, the lateral rectus and medial rectus will contract together. What will happen? They'll pull the eye inside. Okay, not only this, but the eye will also go inside. So this is called as retraction of the globe. Okay, so what do you have to remember? Lateral rectus, instead of getting supplied by the sixth nerve, it is getting supplied by the third nerve. So there is co-contraction of MR and LR together. When they contract together, they'll bring the eyeball inside. This is called as retraction of the globe. So guys, there are so many features of Duane's retraction syndrome that you have to remember. One is this, defected abduction, Next is retraction of the globe. The third one is the upshoot or the downshoot of the eye. Okay, so at least remember this picture. Very, very important question. Now, next one. So ninth image what we have is something about the lattice degeneration. So you can have such a picture along with that a question. So patient comes to you with flashes and floaters, and in retina this lesion is seen. Now guys, what is this lesion? So this is called as lattice degeneration. We have another picture here. Can you see in the mid periphery of the retina you have crisscross lines, isn't it? So you have a network of white lines within some eyeland, and overlying vitreous is liquefied here. So whenever you see such crisscross pattern, the patient is having a lattice degeneration. Now guys, what can happen when your retina is stretched, especially in pathological myopia? You may have some areas of weakness, especially in the mid periphery of retina. Now when you have that, there is a chance that patient may develop a tear in the retina or a degenerative retinal hole. Now when you have that, the patient can complain of flashes and floaters. Okay, so that is what we have typical as a history, right? Now what to do? So this is again a picture question, friends. This is the laser barrage that we have done for the degenerative area. So lattice degeneration if accompanied by flashes and floaters. Not every lattice degeneration, I'm talking about a symptomatic patient. If your patient is symptomatic, you must do a laser barrage, okay? So what are we doing here? These are small laser photocoagulation areas. These are areas where we have done laser photocoagulation. So what will happen? You will just after few months, there'll be all scarring. This will all be scarred. So if scarring happens, then there will be no chance the patient develops a tear. So you will do a prophylactic laser barrage. Clear, friends? Is this picture clear to you? So let me know if I'm clear. All right. So the next topic, next picture is another important one. This is our macular hole. So guys, you have seen so many macular pathologies. Here we have a full thickness defect right there at the fovea. Now as you can see in the OCT here, very, very classical picture, you have a full thickness defect right there at the macula. Now they can ask you what is the most common cause? Is it trauma? No, it is idiopathic. We don't know what is the cause, okay? We don't know what is the cause here. This is mostly a idiopathic hole that is seen with age. So senility is another important cause. Next is when you see directly the sunlight, the hazardous UVB radiations, right? And next can be trauma. So traumatic holes are not very common, I would like to say, okay? People get confused that macular hole must be because of trauma. No, mostly these are idiopathic senile holes, okay? So this can be an important image based question, or they can ask you what is the history and what is the presentation of the patient. So guys, macular hole is another expected question. Now friends, just to make you aware that this is your normal OCT picture, what you see is the normal foveal depression, the normal foveal contour. Now very easily I can tell you, if you see this red yellow areas, these are your hyper reflective areas. So your outer retinal layer and your mostly the inner retinal layer, so both of them will show a slight yellow red areas. So brighter colors, yellow red colors, that means more hyper reflectivity, okay? Please remember, you have to identify which is the outer area, which is the inner area. Then you see the foveal depression, and when you see some abnormal OCTs, you will find one of them is important macular hole, okay? So this is a normal OCT picture, the other one was a full thickness macular hole. All right, now, so this was there in your exams last year, guys. Is a very, very important and a typical picture of staphyloma. Now staphyloma, what exactly is this? It is not proptosis, first of all. This is a protrusion of the outer coat of the eyeball with a incarcerated uveal tissue. So here we have an anterior staphyloma. What do we have in this picture, bache? This is your anterior staphyloma. This is a protrusion of the cornea along with iris with it, okay? So first of all, this is the definition of staphyloma. Now We have 5 types of staphyloma. We have an anterior staphyloma. Let us just quickly read this. We have an anterior, intercalary, ciliary, equatorial and a posterior staphyloma. As you know, anterior is what? That you have cornea. Just behind this, the uveal tissue would be iris. That you see mostly when you have a perforated corneal ulcer. Okay. Now, intercalary is what? When you have staphyloma at the limbus. Right? And behind the limbus, what is that iris tissue? What is that uveal tissue? This is your root of the iris. Isn't it? Root of the iris. Now, what about ciliary? As the name suggests, ciliary, the protrusion is at the level of sclera and the uveal tissue behind is the ciliary body. Equatorial is what? You have sclera, underlying this is choroid. Posterior is extreme posterior, basically at your posterior pole. Okay. So these are your 5 types of staphyloma. Now how to identify them through picture? Let us see. The first one here is a intercalary staphyloma, isn't it? The protrusion is right there at the limbus. The second one here is your ciliary staphyloma. Ciliary. And this is supposed to be your equatorial staphyloma. Okay friends, so that is how you have to identify whether this protrusion is in which level. Clear? Now, the next picture is again important, that is a surgical procedure, trabeculectomy. Now friends, trabeculectomy is a surgical procedure where we are creating a partial thickness scleral flap and then we go through it towards the trabecular meshwork and cut a part of the trabecular meshwork, create a peripheral iridectomy and then suture the scleral flaps, and then finally we make a, the conjunctival flaps are also sutured. Okay. Now, as you can see in this picture, this is the typical bleb that is created through the filtering of aqueous humor, and this is a kind of protrusion that we have mainly at the superior limbus, right? So this is a surgical procedure. Now I want you to remember these things. So these are called as shunts or valves. Okay, so we have various types of shunts and valves which are pressure control devices which we place within the subscleral, subconjunctival space. So this is the tube here which is placed in the anterior chamber like this. I hope you can see. And this is your posterior part of that device which is placed under the subconjunctival region. Okay. So this ensures that you have a facilitation of aqueous throughout. Right. Now we have bare-welt valve and we also have a Molteno valve. Okay. So these pictures are also important associated with trabeculectomy. Now, what can be the indications of valve? Why are you placing the valves? So guys, once you have an intractable glaucoma, like in cases of neovascular glaucoma, post-vitrectomy, post-penetrating post-PK glaucoma, inflammatory glaucoma. So these are some intractable glaucomas where pressure is not easily controlled. And in those cases, you can place the valve. Okay, important one. Now, something for our PG students. What is this picture? This is called as silent choroid. Now guys, when you see a normal FFA, this is your choroidal hyperfluorescence that you see when you inject the dye. Okay, the choroidal flushing, that is because of your choroidal blood vessels. So this is a normal FFA, the normal whitish hue that we see from the choroid. But in this picture, you see that the normal choroidal fluorescence is absent. Now, why is this so? The normal white areas in choroid is absent. This typical picture is called as silent choroid. Now, guys, the cause of this is, one of the important cause of this is Stargardt's disease. Okay, Stargardt's disease. So, what do we have in Stargardt's disease? There is a problem in the ABCA, APCA4 gene, isn't it? There's a mutation in this APCA4 gene wherein this gene is important for vitamin A cycle. So when this gene is mutated, the vitamin A cycle is not completed and the waste material from the phototransduction cycle is accumulated within the retina. So basically these are your fishtail specks. The white you see, these are your pisiform or fishtail specks that you see scattered throughout the retina. Now there is a damage to your retinal pigment epithelium and mainly the problem occurs in the photoreceptors and RPE, right? Now, when there is a lipofuscin accumulation in the outer retina, this will mask the normal choroidal hyperfluorescence. That is what you have to remember, okay? So again, because lipofuscin gets accumulated within your RPE and the outer retinal layer, it prevents the normal choroidal hyperfluorescence, okay? So I would say silent choroid is not pathognomic for Stargardt's. This can be seen in other disorders also, but if you have a question related to Stargardt's disease and they mention about the word silent choroid or this picture comes, then your diagnosis would be easier, okay? So I hope the Stargardt's disease and this one is clear. You can have various picture questions related to this problem, okay? This is the most common macular dystrophy, which is autosomal recessively inherited in children. Clear? Now, something related to the picture, but for our Dr. MEI guys, will they be doing these sessions for all subjects? So guys, we have been doing such sessions at DocTutorials regularly. Important questions are discussed, important integrated sessions are there, okay? What else do you want to know? Let me know, please. All right. So we have a picture of hypertropia here. As you can see very clearly, the left eye is going up. Now when this hypertropia picture is there, you can have problem with the vertical muscle palsies, okay? For our FMG students, please remember, this will be there for superior oblique. For you, it will be superior oblique. But for our NEET PG students, you may have some big questions related to the vertical muscle palsies, and there you have to utilize that Park 3-step test, isn't it? The Park 3-step test has to be utilized, okay? So please remember, this picture is important, right? Dr. MEI, what is your name actually? See, I am here for this revision, and I really want, if there's any kind of doubt or any query in your mind regarding the sessions or anything you want to ask to be asked at DocTutorials, please let me know. Clear? Because we are here to clear your doubts. This is a quick revision session where I'm just taking the important topics and important images. We'll be doing it further, of course, we'll be doing that. Chalo, the next picture. So friends, this is about flame-shaped hemorrhages. Very, very important. Please see this when I magnify it. These are the hemorrhages which look like flame. So you must remember, first of all, that flame-shaped hemorrhages are there in the nerve fiber layer mainly. They are more important when you have hypertension and not diabetes, okay? Though they can be seen in diabetic retinopathy also, but they are more prominent when the patient has a hypertensive retinopathy. Now, if I just ask you, what about flame-shaped hemorrhages at disc? So these flame-shaped hemorrhages at disc, if they are specifically on this, then you can say this is mostly for primary open-angle glaucoma or a normal tension glaucoma, okay? Only at disc, not elsewhere. Then you think about POAG or a NTG, okay? Yes, Dr. Biswas, PDF will be available. Yes, it's a recorded session. You can go through it at DocTutorials YouTube channel again. Why not? Beta, Dr. MEI Park 3-step test is a very detailed one. I'll take a quick session again. I'll record a video and make it clear to you again, but it is going to take a lot of time. So today I will not discuss. Okay, Park 3-step test, I'm not discussing it right now. ठीक है बच्चे? Chalo, next. So let us talk about some more questions on hypertensive retinopathy, friends. Again, an important one, especially for our NEET PG students. So what is this copper wiring and what is this silver wiring? You must have heard about these terms. So guys, when your reflex, which comes from the arterial vessel wall, becomes like copperish, becomes brownish, you call it copper wiring, right? Now why does it happen? It happens because there is a vasospasm of the vessels. So when vessels undergo vasospasm, the reflex which appears from the vessels is also disturbed. So you get a copper wiring. Now if I say there is a lot of vasospasm and the vessel has become totally devoid of blood, then this appearance is called as silver wiring. Guys, can you see the white vessels? The vessels are actually devoid of blood. and the reflex that appears from that ophthalmoscopy is called as silver wiring. Okay, so these are two pictures for NEET PG students, right? What we expect from FMG friends is the flame shaped hemorrhages, and this for everyone, guys, this is the grade 4 hypertensive retinopathy, a very typical picture of bilateral papilledema. Here, guys, the disc margin is not at all see. We can't see the disc margin. No, margin is all gone. And what you see in macula, you have a typical macular star appearance, isn't it? So it's very, very important. This is a bilateral papilledema. If we talk about hypertension, this is the grade 4 hypertensive retinopathy, right? So for FMG students, again, flame shaped hemorrhages and papilledema is an important picture, but for our NEET PG students, copper wiring and silver wiring can also be asked. Okay, chalo, next, our 16th important image is this, something from the visual field, something from the perimetry. Bache, now first thing which I want you to understand is, suppose they are given this picture, but they are not mentioning it is left and right eye. They are not mentioning. Suppose if they don't write which is the left eye, which is the right eye. So how do you identify which is the left and which is the right? So the one which is on my left, the one which is on my left is my left eye. Consider this the left eye. And one on my right will be the right eye. Okay. Another thing how you can remember whether it is a left eye or a right eye is to see the blind spots. Guys, can you appreciate these are two blind spots? So please remember, blind spots are always temporally situated, isn't it? Blind spots are always temporal. Why blind spots are temporal? It's because the optic disc is nasal. So when disc is nasal, blind spot will be temporal. Okay, so these are the two things how you can remember whether it is a left eye or a right eye. Now, why I am saying it is a right homonymous hemianopia? Because the problem is towards the right. The patient is not able to see the left nasal half and the patient is not able to see the right temporal half. Okay, this is some kind of picture like this. Okay, here what is happening? If I am talking about this as a left and the right eye, the patient has problem on the opposite side. This is supposed to be a left homonymous hemianopia, isn't it? Because the problems, the defect is on the left side. Am I clear, friends? Am I clear? Yes, you are absolutely right, guys. Left optic tract lesion or the retrochiasmal lesions gives rise to the opposite side homonymous hemianopia. Very good, Dr. Dreamcatcher. Good, good. Okay. So this was about homonymous hemianopia. Is important how to identify whether it is left side or right side. They can give you a picture and they can ask you where is the lesions. Very, very simple. Okay. Chalo. The next set of expected questions. Guys, these are two pictures where students get confused. Whether it is a pachymetry picture or it is a esthesiometer. So how to identify. Okay. And what are these? I'll just let you know in very brief. So pachymeter, guys, it's an instrument by which we measure the corneal thickness. Okay, you should know everything about that corneal thickness, right? Now, if you can see this kind of tip, so this is your ultrasonic type of pachymetry. So guys, we have two types of pachymeter, but this ultrasonic is the most important. This is considered the gold standard. What you have to remember is that this is a contact method. As you can see, we touch the cornea. And please remember, this is the gold standard, not the other one. This is the best one which gives the reading. Now, what is this esthesiometer? So, if you remember, from this pocket bonnet esthesiometer, we check the sensations of the cornea, right? It can also be checked clinically by a cotton whisk test. But here, this is the one which gives you the precise value. Now, what does it has? So, it has a monofilament, right? Which ranges from 6 centimeter to 5 millimeters. Now, what do? We open the whole length. We open an esthesiometer of 6 centimeters length. Okay. Now we touch it towards the cornea with a certain pressure. Now obviously the common sense, the lighter the pressure, the patient feels it. That means better is the sensation, isn't it? With the lightest of the pressure, if the patient is having the sensation, that means he has a good corneal sensation. Okay. So what you can remember is the shorter the length, gradually we pull it off. Gradually we decrease the length of the thread and increase the pressure. Now the shorter the length means decrease in the sensation, because when we shorten the length, it increases the pressure. Clear? Is that clear? Chalo, so this was about esthesiometer. Now the next picture, very commonly asked. Every year they give you questions from diabetic retinopathy. So you need to know everything, guys. You need to know what image is there. So here today I'm only discussing the image here. Guys, we can see that this is your dot blot hemorrhage. Very smaller ones are your microaneurysms. This one is your flame shaped hemorrhage, isn't it? Dot and blot hemorrhage. This one is your small one is your hard exudate, and the large one here is your soft exudate, which is also called as a cotton wool spot. We don't have anything which is soft exudate now, okay guys? We don't have anything like this now. Dr. Hello. Dr. Hello, we don't, Gaucher's disease, I would say, bache, it is the last thing you can say as the cherry red spot. If you don't have any other thing in your MCQ, then you can think about Gaucher's disease, okay? Gaucher's disease में बहुत कम दिखता है cherry red spot, right? And you can see this in type 2 only. That is why I am saying that don't get confused. If you have better options where you can think about cherry red spot, you mark them. But if it has to be excluded, Gaucher's disease will be the last in the list. Am I clear, Dr. Hello, about Gaucher's disease and cherry red spot? Don't get confused, yaar. It's a very bekar ka topic hai ye, hai na? Something about this cherry red spot. But what is important as per my view is a Berlin's edema. Okay, Berlin's edema is a very important topic, something about trauma. So I think that can be your important question, okay? Now, the next. So guys, again we have a stage of non-proliferative diabetic retinopathy, but what do we have here? This is typically a cystoid macular edema. So friends, I would say NPDR plus cystoid macular edema becomes an indication of treatment, okay? This can be an expected question. Otherwise, we generally do not treat NPDR. So we are not treating here this patient. This patient doesn't require any treatment, but here, because NPDR has cystoid macular edema, so this becomes an indication of treatment, right? Important topic. Now, my 19th picture question is about this. So study this picture, friends. We have an optic atrophy, we have a pale disc here. Now, I want you to tell me which type of optic atrophy is this. It's a primary, secondary, glaucomatous or consecutive. So here we have a consecutive type of optic atrophy. Now, what is the clue? So I would say, bache, don't go with only the pale disc. See the retina as well, isn't it? What are we seeing here in the retina? The retina is not supposed to be normal. We have bony spicules here. A lot of bony spicules are seen. And there are so many pigmentary changes right there at the retina. Now friends, this is called as consecutive optic atrophy because we have this damage of ganglion cells secondary to the problem in the retina. Okay, this is called as consecutive optic atrophy. Now what are the examples? What are the causes here? First, the most important is retinitis pigmentosa. We can have this in high myopia, pathological myopias, in retinal detachments, late cases of retinal detachments, okay? So we have so many things here. Very good, Dr. Prithvi. No, beta, no, Dr. Ibiza. It is not pizza pie, bache. It is not pizza pie, parents. Now, a quick look at the rest of the optic atrophy. So white chalky disc, chalky white disc is typical of primary type of optic atrophy, isn't it? This is your primary with sharp margins as well. And here we have the secondary optic atrophy where there's a lot of gliosis, isn't it? You don't have a chalky white disc, but you have a grey white disc, okay? So these three optic atrophy is also very important. They can ask you what are the causes of optic atrophy, after what things you have secondary, what things you have primary, and so on. These are the questions. Now, a quick look on the dyes, guys. Important questions for our NEET PG students, okay? So, but everybody should know about these two dyes at least. Everyone should know. Clear? Now, fluorescein dye is a dye which stains the epithelium defects. So, if at all you have an epithelial defect, erosions of the cornea, or if you have corneal ulcers, you will have this fluorescein dye staining the cornea green. What do you see? You will see a green color on the epithelial defect. This is your fluorescein dye. That's a property of fluorescein. Basically, the dye is of orange color. That is an orange color dye, but when you see this cornea under the blue filter of slit lamp, the epithelial defect appears green. Okay, so fluorescein dye is important. Next important is rose Bengal dye. So friends, first of all, this is a pink color dye. Okay, wherever you see pink, that means there's an abnormal area where either you have a dry eye, because this rose Bengal has a property that it stains the dead and devitalized cells. Okay, it stains the dead and devitalized cells. Now normally, suppose if my cornea, my conjunctiva is very healthy, my cornea conjunctiva will not be stained. But when I have extreme dry eye, then if you will see my cornea, it will appear that is a pink stain there. Now guys, clinically it is a very important dye, the rose Bengal dye. But the problem with this dye is that it is very irritating to the patient. It is a very irritating dye. So if this is irritating, this will not be appealing to the patient, isn't it? So clinically we are not using it. Dr. Basu, I'm not saying indocyanine green is the best dye. No, there's nothing which is called as best bache. Okay, green color is because of the stain fluorescein here. ICG has different uses. ICG is mainly used for retinal staining. Okay, beta? And there's nothing called as best. You have different uses. Like fluorescein is used for staining epithelium. Rose Bengal is mainly for your dry eyes workup. Okay? Dr. Prithvi, is it clear? Dr. Prithvi? Yes, you can say for tear studies, for dry eye workup, yes, we are doing it. Okay? Sometimes, no, not retinal staining. No, rose Bengal dye does not stain the retina. No, rose Bengal is mainly for your cornea and conjunctiva bache. When you have corneal ulcers, keratitis, then also you can use this dye. Okay? Dr. Ibiza, are you clear now? It is not pizza pie appearance. Okay? We don't have it today, pizza pie. We'll discuss it some other day. Chalo, the next image is again important. An image based question can be there. So this is a placido disc. First you have to identify that it's a concentric white and black areas in the disc, and you have a central hole. So mainly once you see the cornea of the patient through this placido disc, like suppose I am the examiner, I'll see through the small hole the patient's cornea. Now when I see this much reflex in the patient's cornea, it appears that the curvature of the patient's cornea is normal. So this is the reflex which I see in the patient's cornea. Okay. Now if I see this, that means everything is okay, the curvature is normal. But what if I see this? Irregular Myers, that means the curvature is not normal. Curvature is not normal. Now what is this on the right side? This is a color coded imaging which is seen when you do a imaging by pentacam. Okay, pentacam is giving you corneal topography. Topography means everything on the cornea. Like where is the cornea thin, every point, where is the curvature, what is the curvature, what is the thickness at every point on the cornea, not only anterior but also the posterior surface of cornea. So what you have to remember, first, placido disc gives you only the anterior surface curvature, only the curvature, not also the thickness. Pentacams gives you the picture of the topography of the cornea. Next, green means green, that you go ahead, green light, green signal, go ahead, everything is okay. But once you see red areas in the center, if you see hot colors in the center, red color especially, that means there's a danger. Okay, they are not going to ask you identify the disorder. We have so many corneal ectasias, they will not ask you what type of ectasia is this, but definitely you can be asked whether it's a normal picture or an abnormal picture. Okay, so normal will be green everywhere, abnormal will be red colors. That means you have excessive curvature or a corneal thinning in the red areas. Okay, so please identify the normal and abnormal. Now similar to that, another picture question can be there related to the keratometry. So this is something what we do before the IOL power calculation. This one is keratometry to check the curvature of the cornea. Yes beta, yes. Dr. Prithvi, we had a question related to that. Yes. So this is your keratometry picture, bache. What are we going to do here? This is called as Bausch and Lomb keratometer. Okay, this is the picture of a Bausch and Lomb keratometer. Yahan pe there is a chin rest for the patient. Yahan pe the examiner will sit and the examiner looks through the opening here. Now, once we look at the cornea, first of all, this picture will be seen. Now what will we do? We will first of all focus on the circles. So these are the focus of the circles, right? I'll just show you by moving like this. So this is how you see the focus on the circles. Okay, circles are focused very well here in this picture. Now the second step is that you focus minus with a minus and a plus with a plus. So this is the end picture. So when you see this on the patient's cornea, you will come to know this is the end point, and then you note down the reading. Okay, this is the end picture, minus with a minus and plus with a plus. This is the end picture. Now what can be the rest of the questions? So friends, they can ask you keratometry is based on which principle? So it is based on Purkinje image number 1. What is that Purkinje image? Purkinje image is when you show a torch of light and you see 4 images. 2 from the cornea, anterior and posterior surface, 3rd and 4th from the lens. So if you remember, the anterior surface of the cornea acts like a convex mirror, isn't it? So what is the basic principle? That the size of the image is inversely proportional to the radius of curvature. So these 3 things you have to remember. First, a picture question like this. Second, it is based on first image of Purkinje, that anterior surface of cornea acts like a convex mirror. Okay? The third question will be, what is the principle? Principle is the size of the image is inversely proportional to the curvature. Okay, these 3 questions are important. Now, similar to that, guys, we can be asked about this picture. What is this? This is the A scan picture of the ultrasound. Okay, now what to see, what to identify? So friends, we utilize the sound waves, the ultrasonic sound waves. Okay, so ultrasonic sound waves are going through the eye, and depending upon the reflectivity, the spikes are received. Okay, this A scan is based on the amplitude. It is also called as the amplitude scan. So the resulting spike, what you get, this is the resulting spike. This is because of the reflectivity of the echo that we get. Clear? Now friends, this area, this is the distance between your lens and the retina. Again, this is the distance between the cornea and the sclera. So what else you can see from A scan? You can measure the axial length. Very, very good. What you can measure? You can measure the axial length of the cornea. Clear? So you can be asked about this picture also. Now here comes the 23rd image. Can I ask you what is the spot diagnosis here? So this is a picture of visual field again, but this is something from the glaucoma. Any diagnosis here, friends? Very, very good. So this is your inferior arcuate scotoma. Look at this picture, friends. Isn't it? There's a defect, this extra black area, inferior arcuate scotoma. Isn't it? What is happening here? What is happening? In the inferior part, it's like a complete arc. There's a defect in your germs area. Clear? So this is your inferior arcuate scotoma. If I just show you what is the normal field, normal visual field is like this. We have just a blind spot here, and here the last picture is clean, clear. There's no visual field defect. Very, very important. This is a normal field. Okay? Very good, Dr. Prithvi. Yes, everyone, this is an inferior arcuate scotoma. Very, very good. Now here a very classical sign and expected question. This is something from your ultrasound B scan. Okay? Brightness scan. Okay, so here what we utilize is again sound waves in the wavelength of 8, in the frequency of 8 to 10 megahertz. Okay, so when you give the sound waves, the probe is there on the isn't rule. No, Dr. Prithvi, it is not related to isn't rule. Isn't rule is there in the glaucoma as a normal thickness of the rim. Definitely, but we are not talking about isn't rule. Yes, definitely isn't rule is there. Chalo, so what is this T sign, friends? T sign is this. Please identify. This is the T, first of all. Identify the T, right? Now, what exactly is this? Now friends, normally when we do ultrasound B scan, we see this as the shadowing of the optic nerve. So this is your normal thing, but this is abnormal. So here what is happening? There is a collection of fluid. The collection of fluid in the subtenon space. Okay? Theoretically they have asked you this question many times, but about the picture, you must know how to appreciate this T sign. Okay, so this is characteristically seen when you have a posterior scleritis. Okay, so patient can have a proptosis, a painful proptosis, unexplained basically. Okay, unexplained proptosis, a painful one, and when you get a imaging done, you get something like this as fluid in subtenon space. Okay, yes, there's a shadowing here at the optic nerve which is normal, but what is abnormal is this part is abnormal. Fluid is collected in the subtenon space, right? Good. Now here the next and the last picture is about cryptophthalmos. So what is cryptophthalmos, friends? It is the fused eyelids here, or you can say the absence of eyelid, because the skin is continuous from your forehead to your cheek. Okay, the lids are not formed. Okay, picture question, guys. This is a congenital anomaly, a very rare one though, but yes, it is there. Now guys, if such a picture is there, what about the eye? So eyeball may be rudimentary, may be malformed, a very small malformed eyeball may be there. So cryptophthalmos can be unilateral, it can be bilateral, it can be associated with a small malformed eyeball also. Alright, apart from that, you must know what is the difference between microphthalmia and nanophthalmos. Can anybody tell me what is the difference between these two? The name is slightly confusing, micro and nano. What do you mean by that? Is nanophthalmos extremely small eyeball and micro is a little small eyeball? Can anybody tell me what is the difference? So microphthalmos is a small eye but a malformed eye. Okay, a small but a malformed eye. It can occur as a isolated problem, or it can be associated with various syndromes, right? And few complications as well. And nanophthalmos is a normal small eye. Okay, a normal build, a small eye, right? So this is the basic difference between a microphthalmic and a nanophthalmic eye. I hope this is clear, guys. Is this topic clear to you? So now let's just wait to be here with the students. There's a lag of few seconds, I suppose. So these were the 25 images which I was talking about. Go through all the images. Okay, we'll do that. Before we end the session, let us just quickly go through the images again, because some students joined late. So welcome to the session. And okay, thank you very much, Dr. Dreamcatcher. We will be doing definitely. Yes, we will be doing more such sessions. See guys, at DocTutorials we are also trying hard to make you aware about the importance of the integrated sessions, some important topics which we are doing, and every day we are giving you some quick bites from each and every faculty. Are you going through it, guys? So be connected with us at DocTutorials, at the YouTube channel. We have a Telegram group also, right? So everything we are Hi Dr. Veera, how are you? Okay, so I think now we can just quickly go through the images again very quickly. In 5 minutes we'll just complete it. Okay, those who joined late, they can go through it. So lid retraction, the first lid sign in thyroid, Deller-Impel sign, you have extra opening of the lid. Second sign from this is the von Graffi sign, which is lid lag on looking down. Next is the hyperoleon, which is silicone oil in anterior chamber that you see after pars plana vitrectomy. This is the next picture where we have a cherry red spot. I told you it is with CRAO, and other disorders are also there. Cherry tree never grow tall in mud and sand. But more important for our PG students is a perfused cilio-retinal artery, or another question where you have problems only at cilio-retinal artery. Okay, so you have white retina only at the central area. Please remember cilio-retinal artery. Okay, cobblestone papillae, large huge papillae. We discussed more things about VKC. Some important signs, Denny Morgan signs and Maxwell Loin sign also. I told you Shields ulcer is only in the upper part of the cornea, and there is a similar picture with giant cell papillary conjunctivitis, but the history will be different, right? Next is your umbrella pattern of CSR. I told you about negative and positive scotoma. We discussed the halo reflex. We talked about ink blot pattern also. Next is the fluid gets collected in the subretinal layer on OCT. We have discussed about two instruments, keratome for clear corneal incision in the cornea, and we spoke about the tunnel which we create from the crescent blade in small incision surgery. Bullseye maculopathy, I told about you the dosage and the duration. This is more important. Next is Duane's retraction syndrome, where it is a close differential diagnosis of 6-nerve palsy. You must see the retraction of the globe. Next is lattice degeneration. I told you there is a crisscross pattern. Okay, laser barrage can be done for what? For a symptomatic lattice, not for every lattice degeneration. Okay, we have a full thickness macular hole. The etiology is important. Idiopathic is the most common cause, and a OCT picture. You should know about how to identify a normal OCT, then only you will see the pathologies. We discussed about 5 types of staphyloma as well, how to identify them with pictures and what exactly these are. Next is the picture of trabeculectomy, and I told you some kind of valves also. Next is an important question for our PG students, something about the silent choroid, right? You have lipofuscin accumulation, and there is the normal FFA, and I told you these are the pisiform fishtail specks at the level of RPE and the outer retina. Okay, bache? Next is the hypertropia, and you must know everything about the Park 3-step test. That I'll take again a short video. Okay, I'll make a short video and again post it. So we have flame shaped hemorrhages. I told you flame shaped hemorrhages at disc will be with POAG and NTG, right? I told you about copper wiring and also the silver wiring, and this is the bilateral papilledema, that is on grade 4 hypertensive retinopathy. Then we discussed about right and left homonymous hemianopia, how picture questions can be there. They can ask you about the lesion, where is the lesion. Then we have pachymeter, how to distinguish it from esthesiometer. We have non-proliferative diabetic retinopathy with a cystoid macular edema here in this picture. We have consecutive type of optic atrophy. We should identify why this is consecutive and why not a primary and why not a secondary. Okay. Then we have 2 types of dyes that I discussed. Placido disc was the next to check the anterior curvature. We have pentacam picture here that tells you about the corneal topography. And here we have keratometer. This is the end point, and I told you about the 3 questions. This is your ultrasound A scan for biometry again. And then we have this inferior arcuate scotoma, the normal visual field, T-sign expected question in posterior scleritis. We have this as a cryptophthalmic eye. Okay guys, so I hope you learned something new and something which you were able to revise. So we will be connected again at DocTutorials. We will be taking more such sessions. And whatever you want us to discuss, like I got to know that you want a topic of Park 3-step test, and any other doubts you have, you can please write down to us so that we can conduct more frequent sessions and we'll be connected to you. Anything guys? So thank you, Dr. Me. Do write to us, friends. Be connected at DocTutorials, the YouTube session, at the Telegram group. You will be shared about. I'll share the link with you. You can tag me and other faculties as well. We'll be very, very happy to help you in your preparation. So guys, be positive. Have a positive outlook for your exam. These are your most important and your precious days, guys. Don't waste your time and excel in your preparation, okay? So best of luck. Bye-bye, and we'll be connected again. Thank you. अच्छा यार, I can speak a lot, है ना? I talk a lot actually, so I can revise everything very, very, very quickly. without a break. Acha, thanks, Dr. MEI. I've got so many hearts in that live